Yes, sir. I'll start, sir.
Yeah.
Yes, sir. Good evening. Today's topic is on acute lower limb ischemia and aneurysm. Uh, as per the 2007 Inter-Society Consensus for Management of Peripheral Arterial Disease, they have defined acute limb ischemia as a quickly developing or a sudden decrease in limb perfusion, which usually uh, it, contributes to producing new or worsening symptoms or signs, and often it is associated with threatened limb viability. The incidence of acute limb ischemia is around 1.5 cases per 10,000 persons per year. Going to the etiology, also in addition, acute limb ischemia is also defined in a period of 2 weeks uh, after the onset of the acute event, and beyond 2 weeks, this is considered to be chronic lower limb ischemia. Going to the etiology broadly can be divided into native arterial thrombosis, embolism, and injury. A native arterial thrombosis is most likely to occur at a site of a pre-existing atherosclerotic plaque. This thrombosis can also occur at the site of location of an aneurysm or a site which is previously being affected by dissection. So, atherosclerotic plaque, if there is an existing atherosclerotic plaque, occlusion of this can occur by two mechanisms. One is by progressive narrowing, which will result in low flow and eventual thrombosis. And the second is intraplaque hemorrhage, which will and local hypercoagulability. Then the Going to the next point, the associated with native arterial thrombosis is aneurysm. Uh, Acute thrombosis of an aneurysm can lead to profound uh, lower limb extremity ischemia. Uh, this clinical scenario, however, is more commonly associated with popliteal artery aneurysm, and this aneurysm can also be associated with distal embolization. The third point in native arterial thrombosis being dissection. So, in any acute aortic or peripheral artery like iliac dissection, these can result in malperfusion of the extremities as well as the other organs, and the leg ischemia can occur in rarely, but leg ischemia can also occur in aortic dissection. uh, and Occurrence of lower limb ischemia by aortic dissection is a marker of extensive dissection, and therefore it is associated with extensive morbidity and mortality. Uh, Further, there are other conditions which are these hypercoagulable states, which can be in conditions like malignancy, antiphospholipid antibodies, and hyperhopocystinemia. All of these or even heparin induced thrombocytopenia, all of these also make predispose a person to developing
Sir, Shravan sir has joined, sir.
Yeah, Shravan, good evening. Hello.
Srikanth sir and Niranjan sir are also there, sir.
Yeah, I saw that.
Okay.
Good evening, everybody. Shravan, good evening. Welcome.
I joined 15 minutes back. Now you are introducing.
Illa. I saw that. I thought Madhidal question ಕೇಳಕ್ಕೆ ಹೋಗ್ಬೇಕು.
Continue.
Continue. Einass,
Yes, sir.
what is the dissection that? Who's that? What is the dissection which causes ischemia, profound ischemia? What kind of dissection? Usually, which segment of the aorta dissection is, what is the critical thing? Do you see a lot of dissection in the abdominal aortic and your abdominal aorta?
No, sir.
Where is it more common? Anybody else? Nikita and Praveen? There is golden silence. Come on. Nitya? Where is dissection more common and which can lead to profound, abdominal and lower limb ischemia?
So thoracic, not sure, sir, but
in thoracic also, it's, I think one is arch, second is of course descending aorta. I think they are the two common areas which cause dissection. I think Shravan, abdominal aortic and aortic dissection is much less common. I don't know. I have not heard of much of aortic dissection in the abdominal aorta. I think it's mainly the arch and the descending aorta. Shravan, can you hear me? Is he there or not?
Sir is there, sir.
But he is not answering. When I greeted him also, he didn't answer. So see if he is muted or something.
He's mute, sir, but sir only will. And I called him. Sir said he's already logged in also.
But is he being is he visible as being logged in?
Just call him and then
Yes, sir.
confirm.
Yes, sir. He is, sir, is visible as logged in.
Shravan is not answering. Niranjan, dissection of aorta. Srikanth.
Yes, sir.
Dissection of aorta more in thoracic region. Aneurysm is common in abdominal region.
Correct.
Yeah, I also know.
Okay, carry on now.
yes, sir.
See where is the other scenario of acute limb ischemia with the aneurysm? You said either the thrombus inside the aneurysm can get dislodged distally, and that can cause occlusion, and
Yes, sir.
and also there can be complete thrombosis of the aneurysm, which can happen usually in the popliteal artery, which I agree with. What is the other scenario where acute limb ischemia is associated with aneurysms?
Sir, like rupture, which is resulting in an emboli, sir. In those conditions also.
In rupture, why should it embolize? In rupture, it doesn't embolize, but it can, because it has ruptured, the blood supply to the lower limb can be affected, of course. So
yes,
that
sir.
can compromise. But more than that, what else can happen? Anybody?
Sir, like,
Post aneurysm repair, either clot or plaque during repair manipulation, the clot can get dislodged, and then the aneurysm is working well, but the patient develops acute limb ischemia. That is not, I don't know that is more common now with the stenting, the stents that they put in now. They will obviously protect it, but still that used to be one of the common scenarios. Patients developing aortic aneurysm and repair, and then post that patients would develop acute limb ischemia because of dislodgement of the thrombus and the plaque or whatever. Is Shravan there or not?
Yes, sir, I'm here, sir.
Shravan,
yes, sir, that's a very valid point which you raised, sir.
What is the scenario with the current endovascular stenting? Is the limb ischemia still a common thing, or is not so common as before?
Not so common as before, sir.
How do you protect the dislodgement of the thrombus? See,
Sir,
the thing is,
yes, sir. Sir, one thing is we are not touching the wall, no, sir.
yeah,
So we may not disturb the mural thrombus. Second thing, where most of the present situation, the reason of acute ischemia is more of the access vessel related issues, sir. When we go through the common femoral artery, if it's a diseased common femoral artery,
yeah.
that may cause the acute ischemia post procedure rather than the aneurysm itself, sir. That is what the new issue we are seeing now, sir.
Okay, right. Okay. And any particular reason why the dissection is more common in the ascending the arch and the descending aorta rather than in abdominal aorta is because of the support of the retroperitoneal structures to the abdominal aorta, or
Sir, two reasons, sir. One is the area beyond the left subclavian, sir. That region, it is developmentally the wall is slightly different, sir. The collagen proportion, collagen 1 to collagen 3 proportion between the aortic arch and the descending thoracic aorta, it changes from the left subclavian, sir. So that is why most of the type B dissections we see just beyond the subclavian, sir.
Okay.
That is one reason. Second is that ligamentum arteriosum is attached there. So it fairly keeps a hold on the aorta there. So again, that is one reason why thoracic aorta is more common, sir.
Does the dissection of the aorta, does it cause lower limb ischemia also? Can it be extensive and cause lower limb
Yes,
ischemia?
sir. It can, sir. It can, sir.
Yeah.
If it extends all the way to the aortic bifurcation in the abdomen,
yeah.
One of the limbs coming from the false lumen that can go into malperfusion and acute limb ischemia, sir.
Yeah. Okay. Right. Carry on, ma.
Yes, sir. Going to the
Yes,
in the next part, that is embolism. The etiology of embolism is caused by material which has traveled from basically it is material which has traveled elsewhere from the body So basically the clot which has dislodged from one point and has gone and lodged into the extremity, decreasing the blood flow, causing occlusion or severe stenosis of the blood vessel.
Not stenosis, not stenosis, occlusion. Where
occlusion.
Stenosis is a pathological phenomena in the wall of the artery. You can't call it stenosis.
Sorry, sir.
It is occlusion. Okay.
Yes, sir. Causing occlusion in the blood
But
vessel.
if there is already stenosis, then even a small clot can cause complete occlusion. That's all. But the clot will not cause stenosis.
Yes, sir.
Okay.
The etiology for embolism being cardiac sources. Around 55, this is one of the most common source for lower extremity emboli, which accounts for around 55 to 85% of the events. And the main source of the embolism from the heart are within the cardiac chambers. This can usually come from the left atrium, which can usually associated with an event of atrial fibrillation. Further, there can be a thrombus formation in the left ventricle in case of severe cardiomyopathy or in the post MI period, which can further contribute to embolism. And usually in these cases, there is a relative stasis within the heart, which allows the thrombus to form and then further get dislodged and embolize to anywhere in the body. Other than these, the aortic and the mitral valve can also be sources of embolism to the lower extremity. This can be in the form of debris on a diseased or a prosthetic valve, such as the vegetative growths which are seen in bacterial endocarditis. And it can also be a septic emboli from cardiac valves, which can go and lodge in the lower extremity. The next etiology being aortic plaque. Herein, a diseased aortic valve will have a complex atherosclerotic plaque, and this can be a source of emboli. This can happen either following the rupture of the fibrous cap, or because of luminal irregularities and ulcerations, which make the surface more thrombogenic. The third point being aortic and peripheral aneurysm. Blood flow within aortic aneurysms is altered, such that mural thrombus is usually frequently formed within the aneurysmal sac. There is no proof that there is an association of embolic potential of the aortic aneurysm in relation to the diameter. However, the thrombus formation is common, and dislodgement can occur rarely, but it can be a source of embolization to the lower extremity. And embolism can be happen during the manipulation of the aneurysm during an open or the endovascular repair. Then the fourth etiology being the paradoxical embolism. Herein, paradoxical embolus basically results from venous thrombus that is embolizing to the right side of the heart, and thereby crossing into the arterial circulation. This usually happens in conditions where there is an intracardiac septal defect or right to left shunt in the pulmonary circulation, like basically conditions wherein there is a patent foramen ovale. And the last point being instrumentation. Instrumentation, usually a cardiac or a peripheral intervention can result in lower extremity embolization.
Shravan, the left atrial myxomas, do they embolize also?
Yes, sir, they can, sir. It's the most common cardiac tumor to embolize, sir.
Okay. Yeah.
Again,
when you do the endovascular stenting, that is stent graft.
Yes, sir.
The thrombus, the material that is there in aortic aneurysm. What happens to that? It just gets compressed onto the wall, or?
Sir, most of the time our indication is more than 5.5 no, sir.
Yeah.
So the mural thrombus remains there only, and we always have a space between the device and the mural thrombus, sir, and that also will get thrombosed. So usually the device doesn't touch the mural thrombus only, sir.
Okay. And it is usually a covered stent, right?
Yes, sir. Yes, sir. Covered device, sir.
Okay. Right. Carry on now.
Yes, sir. The concluding the etiology, the native arterial thrombosis, which includes the plaque dissection and hypercoagulable states, embolus, which could be from a cardiac, arterial, or paradoxical embolus. The other it includes injury. These can be either iatrogenic or traumatic. Iatrogenic can be usually at the occlusion which is occurring at the axis site, which can be a complication of again a vascular or cardiac diagnostic or interventional procedure. These complications can usually occur following interventions which are happening during catheterization, and these have been reported to range between 1.5 to 9%. And any blunt or penetrating or traumatic injury, arterial injury, can also lead to acute lower extremity ischemia, and either because of direct arterial injury or because of an traumatic arterial dissection, which is subsequently causing thrombosis or thromboembolism. Going to the clinical presentation, the clinical presentation can be in the form of either acute on chronic limb ischemia or acute limb ischemia. The clinical presentation in an acute arterial occlusion will depend upon the time course of the occlusion, the location of the affected vessel, and it will Also, whether there is an underlying vascular disease, whether there are collateral channels which have been already formed, and symptoms can develop over a period of hours to days. In acute or chronic limb ischemia, here the patients will already have an underlying known peripheral arterial occlusive disease, and they may have undergone prior revascularization procedures, and they will come with a sudden increase in symptoms or with a worsening of the symptoms. And acute limb ischemia, the clinical presentation of acute limb ischemia will be in the form of patients who have a normal underlying vasculature, and herein they will experience acute this will develop very rapidly, and they will have like a sudden onset of extreme pain and other clinical manifestations of acute limb ischemia. The one other manifestation is the blue toast syndrome. This includes digital ischemia. Herein, there is the large vessel circulation is intact, and uh, because mainly because of the small size of the embolic material, they will travel into the end arteries and cause digital ischemia. So the patients here will present with intact pedal pulses, but there will be inadequate circulation to the individual toes. So usually these conditions can be extremely painful unless the patient has coexisting neuropathy or any sort of sensory defect. And the clinical course will vary in these patients. Sometimes it can is associated with complete resolution, and other times that it can progress very rapidly so as to develop gangrene and need for amputation. Going to the clinical features, the 5 Ps which are associated with acute lower limb ischemia includes pain, which is usually located distally in the extremity, and it will keep on increasing in severity and progress proximally with the increasing duration of ischemia. Later, the pain may decrease in severity because of progressive sensory loss. The skin perfusion is affected. So in these cases, cases of acute lower limb ischemia, the temperature, color, and capillary refill, all of these will be affected. So the extremity will be cool, that is poikilothermic, pale or malted in appearance, and with a delayed capillary filling time. In case of blistering of the skin, this is an ominous sign which is indicative of advanced lower limb ischemia. There will the third feature being pulselessness. Here, there will be presence of normal pulses in the contralateral extremity, and whereas absent pulse in the affected extremity, unless there is an underlying peripheral arterial disease in the patient. And on neurological examination, there will be sensory deficits like numbness or paresthesias, which are these are basically signs of early nerve dysfunction secondary to ischemia. And paralysis is a sign of major loss, which will be indicative of advanced ischemic disease. Going on to the examination. So here, the examination will include the all of the factors of physical examination, which is inspection to see the change in noticing the change in color, signs of ischemia, which will be thinning of the skin, loss of subcutaneous fat, shininess.
Einass,
Yes, sir.
don't you have any pictures of acute limb ischemia?
Sir,
It is better to put pictures, no, then you can describe that instead of just going on, like this.
sir, I had added pictures of investigation, sir, but limb ischemia I didn't add, sir.
Acute limb ischemia, 2 or 3 pictures, acute limb ischemia, acute and chronic limb ischemia, 2 pictures, you could describe it nicely instead of all this theory. Okay, anyway, carry on.
Yes, sir. Further, there will be the second findings being palpation. So all of the arteries, that is the dorsalis pedis, posterior tibial, anterior tibial and popliteal artery, femoral, and even the artery, depending on which limb is affected, we'll be palpating all the arteries and looking for pulsations. The next will be neurological examination for to look out for to see for sensory loss, and auscultation is basically into there may be a bruit which can be heard over the artery because of the turbulent blood flow which is beyond the stenosis. So these are the examination findings to look for.
I think it's
Furthermore,
extremely important to all of you to know exactly where to palpate all the arteries. Examiner will ask you. I think you should be very thorough about where exactly you palpate the posterior tibial, the dorsalis pedis, the peroneal, popliteal, and the femoral. You should know that very clearly. Okay.
yes, sir. Then going to the clinical categories of ischemia, they can be classified. So there is this Rutherford's classification of acute limb ischemia, wherein it has been classified into 4 stages. Stage 1 being the viable limb, stage 2A being marginally threatened, 2B being the threatened limb, and stage 3 being the non-viable limb. Herein we in stage 1 there will be no sensory loss, no muscle weakness, and the arterial and venous Doppler will be audible. Marginally threatened limb will be minimal, that is limited to the sensory loss will be limited to the toes, and again there will be no muscle weakness, but arterial Doppler will be intermittently audible and venous Doppler will be audible. Stage 2B will extend sensory losses beyond the toes with moderate to mild to moderate muscle weakness and inaudible arterial and audible venous Doppler. The last stage is the non-viable limb, wherein there is no sensation to the limb. There is paralysis and inaudible both arterial and venous Doppler signals. Furthermore, going to the investigations, these will involve the
Just a
routine.
minute.
Yes,
Wait. Any doubts? Anybody so far?
No, sir.
Samir, any doubts?
Sir, this thinning and all inspectory findings, sir, will we be able to find in acute limb ischemia, sir? Thinning of skin.
Oh, I didn't follow your question. What you said some word. Which is that?
Sir, the inspectory findings, sir, like thinning of skin, the diminished growth of hair and everything. Will we be finding in an acute limb ischemia, sir?
What inspectory findings? I am that word is getting muddled.
All these will not be present because there is no time to develop.
Yeah.
Thinning of skin, shining of hair loss, all those
Adela
things.
chronic
Chronic ischemia.
If it is acute on chronic, maybe you will see them, but in acute limb ischemia, you won't see them. Shravan, any comments so far before we proceed?
Sir, one thing I wanted to add, the cyanosis part, sir.
Yeah.
When the patient comes to us, one way which we try to find out whether the limb is good or not is to look at the blanchability, sir. That cyanotic ecchymotic area, we look at the blanchability. If it is blanchable, that means there is still some hope. If it is not blanchable, then very difficult to make it survive, sir. Because non-blanchable ecchymosis occurs after the capillary level depth is there and there's leak of blood into the subcutaneous plane.
Yeah.
So that is one simple thing which we follow, sir. Just a blue limb doesn't mean the limb is gone. We look for the blanchability. If there is blanchability, there is some hope, sir.
Okay. Okay, carry on.
Yes, sir. In investigations, these will include the routine laboratory investigations, which is the CBC, renal profile. In addition to that, we will the coagulation profile, which is PT-INR and APTT, and supportive investigations such as which includes 2D echo, basically to rule out any thrombus in the atrium or the valves. Further, the vascular imaging, which will include the duplex.
Wait.
Yes, sir.
Samir, which is another important investigation, which I think which always the vascular surgeons are very, very keen about. Apart from the bleeding and clotting profile, all those things she has already mentioned. What is the other investigation which is very critical?
Lipid profile.
So how is lipid profile going to help you, man?
So
Anybody
D-dimer,
else?
sir.
D-dimer again, why
APTT.
will huh?
So fibrinogen levels, like APTT, telling how the clotting is in the patient. So,
Yeah, that clotting profile you already said, fibrinogen, all those things. Nikita, Praveen, Nitya.
Sir, 2D echo, sir. Heart status.
No, yeah, it will help you, but I am talking specifically of the needs of the vascular surgeon. What are they concerned about if they have to do intervention? Creatinine, man, simple creatinine. You have to have, if, for example, if the creatinine is already high, it will limit their possibilities of using, the dye and all those things. So creatinine is very critical for them. And it will also show if the disease, atherosclerotic disease is extensive. Already there is renal compromise. So that will again add to the morbidity. Okay, carry on.
yes. Then followed by that, the duplex ultrasound scan, which will aid in localizing the where the clot is. For CT angiography is the preferred modality, because this will it is a useful intervention, giving us the entire complete vascular imaging and showing appropriately where the clot is and which segment of the blood vessel is compromised. MRI is also MR angiography is also an investigation which can be useful, but however, it is the limitations include the additional time that it requires to complete the study, whereas CT angio can be the results can be achieved in 15 to 30 minutes. Furthermore, the extent of calcium within the walls of the vessel is relevant because this will be poorly visualized, and the spatial resolution will be affected, especially in cases of MR angiography. The use of digital subtraction angiography is when we are planning for an intervention. So that is when DSA is being considered, and we do this on table. This is a like the acute limb ischemia, which is being shown. This is a CT image, wherein we can see that there is a complete thrombotic occlusion in the left popliteal, popliteal segment. So beyond that, there is no visible blood flow which is seen. Even here, we can see that there is a complete absence of blood flow in the popliteal segment. Going to the management, the management of acute limb ischemia can be either by intra-arterial thrombolysis, open embolectomy, or percutaneous embolectomy. Intra-arterial thrombosis, herein we will, the indication is basically whichever limb ischemia is fitting within the criteria of Rutherford's 2B criteria, and the symptoms, the onset of symptoms is that of less than 14 days. These can be considered for intraarterial thrombolysis. Furthermore, when there is an established acute embolism or even in popliteal artery aneurysm, these are the indications, and even after thrombosis of following revascularization. All of these are considered to be the conditions for like indications for intraarterial thrombolysis. The contraindications can be divided into like major contraindications and relative contraindications. The major contraindications are like any in history of recent TIAs, like a transient ischemic attack. If the patient has had a history of recent GI bleed within the last 10 days, or a recent neurosurgical history within the last 3 months, even a history of recent intracranial trauma, these are the major contraindications. And relative contraindications can be a history of recent cardiopulmonary resuscitation. If the patient has uncontrolled hypertension, a systolic of more than 180 and diastolic of more than 110, and like recent major non-vascular surgery or trauma, and any uh, even if the patient has is a known case of any intracranial tumor, these are again considered to be like relative contraindications for intraarterial thrombolysis.
Just a minute, Shravan.
Yes, sir.
Shravan, are there any changes in these indications and contraindications? Hello? Shravan? I don't know whether he's there or not. Tanya, any difference in opinion regarding the indications and contraindications?
Sir, no, not that I can think of, sir. I think that's all.
Praveen and Nikita, they are not talking at all. Praveen and Nikita?
Yes, sir.
Any addition, subtraction of indications, contraindications?
No, sir. It's almost the same.
Okay,
No,
carry
sir.
on. Carry on, Einass.
Yes, sir. Yes. In thrombolytic agents, these include tissue plasminogen activators, and they can streptokinase and urokinase. Tissue plasminogen activator is derived from the vascular endothelium, and it is artificially like produced RTPA, and the mechanism of action is the direct activation of plasminogen. It will when we are infusing it IV, it is going to remain inactive in the circulation, but when it connects with the fibrinoids of the thrombus, it will activate and thereby cause plasminogen conversion to plasmin, and degradation of the thrombus fibrinoid. Streptokinase and urokinase, plasminogen activators, they are the first generation plasminogen activators, but they have a similar mechanism to RTPA, but the specificity to fibrin is lower in comparison to RTPA, and like a few papers suggest that they are associated with a risk of more hemorrhagic complications.
And what is the other problem with streptokinase? Anybody?
So the half-life is like 18 minutes for that, sir. So
no, but where is streptokinase derived from? Anybody?
So allogenic, reaction, sir, it can cause.
It can cause allergic reaction. Yes, I agree.
Yes, sir.
No, but where is it derived from?
The
Anybody?
bacteria Streptococcus, sir.
Streptococcus, sir.
Are you sure? Just check that.
Yes, sir.
Yes, sir.
Yes, sir.
It's a beta.
Streptococci only, sir. Beta hemolytic streptococci.
Is it not, sir? Is it something else?
I think it is something else. I will not tell you what it is. But the
Okay, sir.
major problem with streptokinesis, if it is being given recently, you can't use it again because it will cause what, not allergic reaction, but it can cause what is that? What can it cause? What is the more severe form of allergic reaction?
Anaphylactic.
Anaphylactic reaction. So I think if streptokinase has been used recently, you can't use it again. But there's no such problem with the recombinant tissue, the plasminogen activator or RTPA. I think that is probably the preferred agent now. Previously, because of the overwhelming cost, people used to use streptokinase. I don't know. I think it would be nice if Shravan is there. Shravan not there? He's probably gone. I think he's taking a call or something. Or
There
he's,
is.
huh?
Sir
He's
is not there, sir.
Yeah, I think he's on emergency or something. I don't know. But it would have been nice because he'll give you the latest what they are using. What I am telling you is what we used to practice. That is why it would be nice if somebody who's practicing regularly can talk about these things. So describe are you talking about using systemically or local thrombolysis? Einass?
Yes, sir. Like systemically, sir. Like how we access the artery, how to cross the thrombosis, sir. I'll speak about it, sir.
Yeah.
Yes, sir. So the technique is the pre-procedure evaluation. First is the main pre-procedure evaluation, which will have the vascular imaging, doing the baseline laboratory investigations. Further, there are catheter devices. These are the CDT, catheter-directed therapy. Which will include the infusion catheter systems, and basically these CDTs allow enzymatic clot dissolution, and these have been shown to be effective in distal small vessel or infrapopliteal region arteries which have been affected. And so basically in the technique, we have the intraarterial thrombolysis technique, wherein first will be gaining access to the artery, which will be generally obtained via ultrasound guidance, percutaneous access. Usually it is to the common femoral artery. We also have to ensure that you don't make multiple access attempts so as to avoid trauma, especially when we are administering the thrombolytic agent. So you can either have retrograde access or antegrade access, which can be this depends on the operator comfort, and also like before this initial arteriography, a diagnostic angiogram needs to be is performed, and after and after this, the sheath is then changed for a 6 French sheath for most CDT systems. After this, the attempts are then made to cross the occlusion with a wire, followed by first you insert the guide wire, followed by the infusion catheter, and like if we are able to easily cross the thrombus, this is a positive prognostic factor, which is sort of indicative of a successful thrombolysis. And if we are unable to cross the lesion, then the catheter is to be positioned just proximal to the occlusion. And we also have to make sure that the catheter remains intraluminal and it should not enter into the subintimal layer.
Dissection.
Yes, sir. To avoid dissection. Then position. After this, you position the catheter either into the thrombus if the occlusion can be crossed, or just proximal to it if you cannot. And then the thrombolytic agent is infused through
Do you give heparin first?
Yes, sir. Like concomitant heparin administration is done, sir. Like
first you have to give a loading dose and then you have to continue infusion of heparin.
Yes, sir. Around 5,000 international units is the initial dose, sir.
Correct.
And after that, like 500 units per hour is what is
500 to
administered.
1000, 500 to 1000 units per hour.
Yes, sir. That is what is administered during the procedure. This is mainly done to limit the thrombosis of the sheath. After the initiation of this.
Not just that. I think even the heparin has the ability to dissolve the clot. It will augment the effect of the thrombolytic agent also. So it will also dissolve the clot, not at the same rate as the thrombolytic agent, but it does. So which is why not only you have to maintain a status of blood that doesn't clot, especially as you said rightly, because you have instrumented the vessel, there can be clot relating to the instrument itself and the sheath and the catheter. So that obviously will be reduced by using heparin, but in addition, heparin also dissolves the clot. Okay,
yes,
carry on.
Yes, sir. After the initiation of CDT, then so you shift the patient to ICU and you monitor the limb for improvement or worsening limb ischemia. Other than these, you also look for compartment syndrome, bleeding, or any other complications which like acute neurological changes. Hourly neurovascular checks are performed so as to look for clinical deterioration in terms of motor or sensory function, and any indication that the ischemia is advancing. This will this is an indication for taking up the patient for surgical revascularization, which can be usually embolectomy.
See, the other thing is there is facility for clot suctioning the clot. I think the same through the sheath. There is facility to suck the clot also. It can be done, especially if it is soft, if it is embolus, and after you have started the thrombolytic agent, you can use the sheath to apart from dissolution of the clot, you can also suck it out so that the perfusion becomes better. I think Nitya or this one call up Shravan and see if he's because it would be nice for us to have his inputs, because he does this regularly. One of you call him and find out what's happening. Okay, carry on.
Yes, sir. Then the patient is closely monitored for any signs of bleeding complications. EPTT values are to be monitored every 6 to 8 hours while the catheter is in place, and based on these values you will titrate the lytic infusion and also make sure make sure that the adverse bleeding events, that is mainly intracranial hemorrhage, is avoided.
What is the maximum dose you can give of TPMA?
Some maximum dose, so usually they
Anybody else? Nikita, Praveen? I think that's a homework for you guys. You have to put it up in the WhatsApp group?
Yes,
Is
sir.
there a maximum dose that you can give? Because I think it is a balance between achieving thrombolysis and causing hemorrhagic complications elsewhere.
Sir, Shravan's number is coming busy, sir. I think
I
he
think
is having some calls, sir.
emergency. Yeah. Okay.
Okay, okay.
Okay. If he joins back, then we can get some clarifications of certain things if there is any doubts in your minds. Okay. Carry on.
Then the repeated arteriography is considered so as if the initial progress is slow, that is when you consider this, and then the infusion rate can be also increased to around 1.5 to 2 milligrams per hour. Then the infusion can be continued up to 2 to 3 days, provided the extremity is not threatened and the bleeding concerns are minimal. Then going to embolectomy. Again, embolectomy can again be classified into open embolectomy and percutaneous embolectomy. In the open embolectomy, basically will be you make the incision and we are passing the Fogarty's catheter for the procedure of open embolectomy. The main advantage of open embolectomy is that the blood flow will be restored quickly. However, the revascularization may be accompanied with adverse cardiac events and such as sudden release of acid and potassium, which can cause advanced ischemia. So usually you may if there are you make a transverse or longitudinal incision, this can be made over the common femoral artery. Then we ensure that the vessel is healthy. After that, a transverse arteriotomy is made for embolectomy. If the incision is made and if the artery is diseased, then you do make a longitudinal incision because this will provide greater flexibility. From that arteriotomy, you pass a Fogarty's catheter proximally into the iliac artery distal and going distally into the superficial deep femoral and then down the popliteal artery. And usually like number 5 or number 4 Fogarty's catheter is sufficient for this. And after that, once a strong inflow and back bleeding is obtained, then and there'll be a clean passage of the Fogarty's catheter. You go beyond the embolus, inflate the balloon, and then sort of pull back the catheter so as to remove the emboli. And other than this,
Wait.
yes, sir.
What else? What other precaution? Has anyone seen the embolectomy being done? Recently, you saw it, no?
Yes, sir.
What other procedure? It was lower limb embolectomy.
Yes,
Yes,
sir.
sir.
Lower
Lower
limb
limb embolectomy.
Yeah. What did Shravan do when he did the open embolectomy?
Sir,
Did he
sir,
secure
first,
the?
sir, first found out where the emboli is, and then he inserted the catheter, sir. And then once he inserted, it could pass beyond the embolus, and he inflated the balloon, and then he started retrieving it, sir.
Yeah.
Retrieving
But
the balloon so that the clot got dislodged,
did
like
he
it came
secure? Did
out.
he secure the profunda?
Secure as in, I didn't understand, sir. Like,
Tape.
sir went to the.
Did he tape the profunda?
No, sir. No, sir.
That used to be followed. I think they used to put a tape to the profunda because you don't want the clot. Normally, profunda is generally not affected by atherosclerotic procedure. Atherosclerotic plaque. Profunda somehow seems to be spared. So you don't want the thrombus to get into the profunda because the the ostium of the profunda is there, close by. So the clot can enter that. So I think usually you tape it so that you prevent the clot from entering into the ostium of the profunda femoris. And then you check for back bleeding from both the profunda and the SFA, and then look at the inflow also from the iliofemoral segment, and then close the arteriotomy. So did you ask Shravan, do they prefer transverse arteriotomy or longitudinal arteriotomy?
That day, sir did a transverse arteriotomy, sir.
But did you ask that question? Is it I think Einass said it. If the artery is diseased, you prefer to do a longitudinal. If it is supple and soft, you probably prefer to do a transverse. And again, it depends on the size of the artery. If they are small sized arteries, I think you would prefer a longitudinal, because if you do a transverse, then it could potentially narrow the vessel. So again, it depends on the size of the vessel also. Srikanth, anything to add? Niranjan, anything to add?
I think these are all advanced procedures, so
Nothing.
Shravan would be a better person.
Shravan Bandilainu, okay.
Because we have not seen all these procedures. I think you should have shown that slide of that. Percutaneous embolectomy, how they do.
So I tried finding videos, like only like I just
No,
found this.
Shravan will be having, he does so many cases.
Yeah.
Okay.
Yes, sir.
Okay, carry on.
Yes, sir. In percutaneous embolectomy, again, these are it's a catheter-based thrombus extraction using guiding catheters, either to so as to directly aspirate the embolus. They are useful for cases wherein the embolization, basically intra-procedure, there will be embolization of the plaque, and these plaque or thrombus will be large enough that they will lodge off into major runoff vessels. And in cases where there is a contraindication in the use of thrombolytic agents.
No, I think mainly acute, acute embolism, where the clot is likely to be soft. That is where it is better compared to the well-formed thrombus, which is already organized. If it is firm to hard, then I think much more difficult to retrieve it percutaneously. Carry on, ma.
Yes, sir. Then going to compartment syndrome. Compartment syndrome is one of the like an important and major complication which can occur following any sort of intervention. This is basically associated with an ischemic reperfusion injury. The pathophysiology behind it being that following any intervention, there is there is development of edema, because of which the compartment pressure, because of reperfusion, and there will be injury, and such that the compartment pressure will rise, and once it rises to beyond 30 mm of Hg, the muscle oxygenation decreases, and this will result in the development of their acute compartment syndrome, and this will further result in the final common pathway will be that of cellular anoxia because of local ischemia. So this is the pathophysiology, and the manifestation will basically be in the form of pain, which is out of proportion to the visible findings, and there will be this will be persisting and deep aching pain. Patients can also be complaining of paresthesia. In addition to this, the examination findings will be like when we are passively stretching the muscles, there will be pain. The presence of pallor and diminished sensation and paralysis, which is a late finding. So compartment syndrome is mainly a clinical diagnosis, but for like the laboratory investigations which can aid in sort of helping to confirm the diagnosis is measuring the serum creatinine kinase levels. Elevation in these levels is highly suspicious of compartment syndrome. And also we look for myoglobinuria, because myoglobinuria will develop within 4 hours of the onset of compartment syndrome. And the one other technique is you use there are you can use devices to measure the pressure. One such device is the striker pressure monitor, which will be used to measure the we basically insert the needle directly into the muscle, and the device will help in measuring us the it will help in measuring the pressure inside, like in the compartment. And the development of acute compartment syndrome is an emergency condition which will require management in the form of fasciotomy, wherein you do fasciotomy and make 2 incisions, one at the lateral compartment and one lateral incision and one medial incision, so as to decompress all of the involved compartments. This is for compartment syndrome.
I think we can stop here because it's already 10 o'clock.
Yes, sir.
So I think the other homework is for all of you. When will you consider doing prophylactic fasciotomies in patients whom you already reperfused? When will you wait for it to develop, and when will you consider doing a prophylactic decompression or fasciotomies for compartment syndrome? So I think that is probably enough for today. I think the homework you put it up in the thing, and we'll do the aneurysm class next, because that itself is a big chapter. So questions, comments? Nikita, questions, comments?
No questions in specific, sir.
Why are you so silent today? Both you and Praveen are, they're not answering any questions, not asking any questions. Is she very clear what she said?
Yeah. So she put it up very well, all the points, sir, clearly.
But picture,
images were added, it would
Yes,
be.
sir.
Pictorial depiction is very important. She should have taken some, as Srikant suggested, for example, the procedure of embolectomy, one small video of 2 minutes or so, that would have helped. And also the pictures of limb ischemia. I think pictures speak many words. You don't have to, you just put up the picture and explain everything.
Yes,
Srikant, comments?
Very good, very good. Excellent.
Niranjan?
Sir, it was good, sir.
I think you did a good job, Einass, but as these are the improvements you need to make. I think it's always better, in things like this, that you put up the clinical pictures, and also if you have, if you could
It
have,
will leave a lasting impression.
yeah, ask next class, you
Yes,
ask
sir.
Shravan to give you a 1 or 2 minute video of embolectomy and put it up. Okay.
Yes,
Right.
sir. Yes, sir.
Okay. If there are no questions and comments, we'll end the class here. Thank you. Good night.
Right.
Thank you, sir.